Greig. So this is our first trial that we're putting through the RSTN system. It's a really, really simple project, nothing very clever, not groundbreaking, but actually you'd be surprised how much controversy there is in a nail bed repair. It's jaw-dropping. So Aina's going to go through this with you and tell you where we're at the moment. This is our first trial for all you to get involved in.
So thank you very much for everybody for coming today. So why do we look at studying nail bed injuries? Well, they're very common injuries, so we all see them. And it's just, there's a surprisingly wide variation in practice. And this project arose sort of through an idle discussion between me and Abby one evening over a pint. We went, what do you do for nail bed injuries? I do this. What do you do for nail bed injuries? And somebody else does this. And why don't we do a trial to see if this is really going to work? So this is where this sort of, and this whole project has just snowballed because of you guys. So we thought it was a useful question to ask. So what inspired this was a paper written at St George's, which was submitted to PRS and published there, where they showed that there was a difference in infection rates when patients had the nail plate placed and not placed. So we wanted to actually do a proper randomised control trial. So the question our trial is going to ask is, should the nail plate be replaced or discarded after nail bed repair in children? And we don't really know if this matters, and there's lots of arguments for and against, as you can see. So this is the paper. This was published by Ben Miranda and Katie Roy, and they showed a statistically significant difference in overall complications rates and infection rates. And in their study group, they showed that there was an 8% increase, or 8% of patients who had the nail replaced had infections compared to just over 4%. So that was a significant difference. So, and this was an example from their paper of a patient who had an infection. So we decided we'd set up a large multi-centre randomised control trial to generate level 1 scientific evidence to try and answer this question properly. So we held a meeting in February at the College of Surgeons, and I thought we'd get like 5 people, me and Abby and 2 of our registrars and somebody else from the college. But actually, we had 22 people coming, and 51 people registered an interest on the website, and 18 units so far have been represented. Again, this is snowballed, mainly because of Matt, who's just been running this whole thing on where they're organising it. I think it's just been absolutely brilliant. And we've got this pump priming grant from the BSSH, the Oxford Surgical Interventional Trial Unit, which is just fantastic. So this is actually really going to happen. So this is our study protocol. This is actually what we want to discuss today, because we want to finalise this so we can then submit ethics and get this actually happening and moving. So this was what was discussed in February, and then we've gone away and thought about this, and this is our summary. So I want you to all think about it with us today, and if there's anything that you think we should change, then we're really open to we want you to help us with this. So this is our inclusion criteria. So we're going to look at paediatric patients, so children aged under 16 years of age undergoing nail bed repair. We're going to include crush injuries and sharp lacerations. We're going to include tough fractures. We're going to include all sorts of nail bed injuries, including ones involving the journal matrix. Patients have to be capable of giving consent. The parents have to be capable of giving consent and be willing to return for follow-up. So that's sort of a major thing that we have to include. So the exclusion criteria, so anybody over age of 16 and any fracture involving KY fixation, because that's a different level of injury. So we did a power calculation. These are all preliminary, and this is what we came up with our provisional study protocol. So we need about 330 patients to randomise. We're going to randomise them into 2 groups, divide them 50-50. So those were the nails replaced, and then those were the nails discarded. We're going to follow them up, and then look at primary outcomes between 7 and 14 days. And then we had a long discussion about when we should look at secondary outcomes. And actually, having discussed this in February, we decided that we were going to look at them at 4 months. And again, this is up for discussion, and we can alter this. This is our thought, because the nail cycle is about 4 months long. It takes about 4 months for the nail to fully grow out. And then, obviously, you have to sort of factor in a few patients who are going to be lost to follow-up, patients in each group who complete the trial. And this should give you adequate power to get a statistically relevant study. So this is the surgical technique that, again, we sort of provisionally agreed on, although there are many, and I will go into that in a bit more detail. So we're going to do a nail bed repair with bipropede. We're going to do a patient, if they need a GA, they'll get a GA and a ring block, or ring block alone if they're old enough. They will have some form of digital tourniquet, and they'll have some sort of non-adherent dressing for both groups. We had an awfully long discussion about dressings and tourniquets and local anaesthetic, and it just went on and on for hours. It was amazing, because there really is no consensus. And then, so this is what we've currently decided. So they're going to be seen in a doctor-led outpatient clinic. First follow-up is between 7 to 14 days after the operation, and the second follow-up will be at 4 months. And then, if there's a problem, obviously the patient can come back sooner. And then we're going, as our primary outcome measure, we're going to measure the presence of infection postoperatively, defined as something needing treatment with antibiotics. Because again, you have to define what is infection. And then our secondary outcome measure is the cosmetic appearance of the nail, pain during dressings change, time from surgery until dressing is discontinued, total number of outpatient clinic visits required for probably multiple visits, and any other complications. So what we've done since February is we've done an online national survey of background BSSH and plaster members. And we've also done an audit project in 3 units of all nail bed repairs performed during October 2013, and that will give us enough time to have 4 months of follow-up to sort of see what happens. And then we've also done a parent survey to identify key parental concerns. So these are our results so far of an online survey. So we had 112 responses, 63% from plastic surgeons and 37% from orthopaedic surgeons. 85% of people repair the nail, and 15% don't repair the nail at all. So again, that's a whole nother question. We decided we were going to repair the nail, but again, you know, that maybe that's something that needs to be thought about as well. Because plastic surgeons, I think, usually like to repair nail beds, but anyway, here we are. So then we wanted to know sort of roughly how many nail bed repairs are you doing a week in each of your units. And so you can see most people are doing less than 5. And this sort of fits with what we're doing at St Thomas's and at Chelmsford. And then in terms of antibiotic use, most people are giving comoxiclav. We're giving comoxiclav, Chelmsford are giving comoxiclav. But actually, if you look at the national data, it's not everybody, 65%. So there is a bit of variability in terms of what antibiotic people get given. But it's very interesting to speak to the St George's unit, because they give flucloxacillin and other things because they think comoxiclav is too expensive or difficult to give, or yes. And then there's a lot of variability about when and how you give the antibiotics. So 30% don't give any antibiotics at all. Then some give 1 IV dose and an oral course. Some give 1 IV dose only, and some give an oral course only. So what we do locally is most of them get an IV dose, then a week of oral. I think these are the ones having GAs. And then the ones having oral antibiotics only probably have a local anaesthetic procedure, so they don't get an IV dose. I think it would be really useful to tie in with H's study to see, well, what really is the best evidence for what we should be doing. I think, you know, one study is kind of feed off another, and it's very interesting to see the outcome. And then repair techniques. Again, what sort of suture people are using, there's a lot of variability with that. Most people like bite from repeat, but other people are using PDS bite, or somebody was using monoclot. Who knew? Again, variability in the type of repair. Most, again, people are using interruption repairs. What happens to the nail? How many people replace the nail? How many throw it away? Well, in the national study, 95% of people replace it, and 5% discard it. In our local study at Guys and St Thomas's, again, it's really variable. 62% replace it, 37% discard it. So in my own unit, we're all over the shop, and pretty similar at St Andrews. It was really interesting. And then, if you're going to put the nail back in, then what do you do with it? How do you fix it? So there's a lot of variability in terms of what people do, but the commonest technique is the figure-of-8 suture. And then what about follow-up? Well, again, it's really variable as well. So then, this is the summary of the 3 audit projects. So we have 47 patients from 3 units. We just collected data about past medical history. Most of them are crush injuries. We operated on them pretty quickly, so that's not bad. About just over half of them had no fracture, so quite a few had a tough fracture. Most of them are operated on by a registrar or fellow, and they're not supervised. So this is probably why there's no consensus about what to do, because they aren't getting any sort of senior input or feedback about what they should be doing, or how they should do it, or how we like it done, or anything. Most of them are clean injuries. An awful lot of variability about the suture material and the size of the suture, so you can see that it's all over the shop. Nail preserved in 62%, so again, a lot more variability there. And the method of nail fixation, most people go for figure of 8 suture, but it's certainly not as popular as in the national study, which is interesting. And the antibiotic use, again, is all over the shop, which is just really interesting. Follow-up, most people go to a nurse-led dressing clinic. Here, in the terms of outpatient follow-up, they don't get any outpatient follow-up, which is also maybe not that good. So, in terms of complications from the 3 audit projects that we did from October, 1 patient developed a soft tissue infection requiring oral antibiotics, 1 patient developed hypersensitivity, 1 patient had loss of a fingertip, and that was actually because the injury was a partial amputation, so it was nearly off anyway. So it's much more of a severe injury than a regular nail injury. So our total complication rate was 6%, and no other concerns were reported at 4 months. So this is our sort of data so far. Our online app, we've got the data from the national survey and the audit, and there really is no consensus about what people are doing and what we should be doing. We also thought, just because it's useful for the design of the trial to get some parental involvement, and so we asked, at Guidance St Thomas's, we've just done this recently, we asked parents, and we gave them a questionnaire, what their top 3 concerns were, and we sort of spoke to 12 sets of parents. So most of them have concerns about the nail regrowth, and then this is into the descending order, so infection, losing the fingertip, nail appearance, ability to use the digit. So this is the state of play so far. I'd really be grateful if you could get on board and get involved. We really want to recruit people and get people excited about this study, which I think is really interesting. It's quite a simple study to do. It can be trainee-led. We want to finalise the study protocol, hopefully today, in the next couple of days, and then get the ethics approval submitted. We've actually drafted the application online. It's 87 pages, so it's taken a while, but we're going to get there. And then we'd like to start recruiting in early 2015, so this is our website. And I'd just like to thank everybody who's contributed to the study so far. Thank you very much.